Good evening, friends. Hi, this is Dr. Tirath Gill. I wanted to talk to you today about bipolar disorder. Bipolar disorder is one of the major mental illnesses that have been around since ancient times. In fact, there are descriptions of the illness in Egyptian hieroglyphics and talking about states of low energy, decreased movements, and states of increased energy or mania. It's also been mentioned in other ancient scholars, medical scholars, in their books. So what is it? What is bipolar disorder? Basically, it means that there are two poles of the person's mood state. There can be, on the one side, well, most of the time they'll be in the normal state, which is called euthymia, okay, E-U-T-H-Y-M-A. E-U-T-H-Y-M-I-A, euthymia. That means a normal mood state. And a normal mood state doesn't mean that you're never depressed. It means that you may have ups and downs, but you bounce back. And so you have the normal mood state. And in bipolar disorder, there's that, and then there's episodes where they're severely depressed. They don't want to get out of bed, they overeat, and they're depressed, nothing can cheer them up, and have low energy. And then it alternates with, at some point in their life course, with episodes of mania, where they're unusually happy, elated, feel like they're Superman, have tons of energy, can't stop talking. In fact, it's hard to get a word in edgewise. Very impulsive. They may have increased risk-taking behaviors, increased sexuality, increased spending. So that's the manic side of it. And bipolar disorder is punctuated by these episodes of normality, depression, mania, and and then it goes on like that. The onset is generally in around age 20, early 20s, late adolescence, early 20s. The prevalence is about 1% to 2%. That is still, 1 to 2% is still a significant number of people. Before we go further, I want to tell you that there are two types of bipolar disorder. There's bipolar 1 and bipolar 2. And it has to do with the two different states of mania, is where the person becomes dysfunctional. They can't hold a conversation, they can't stay focused, they can't, stay in where they're supposed to stay. They're hyperactive, impulsive, may go on, unplanned trips, spend impulsively, make rash business decisions. So that's mania, and that's dysfunctional. That's bipolar type 1. And there's another type of bipolar disorder where they're not quite manic, they're less than that, they're functional, and that's called hypomania. And that condition of hypomania, corresponding with episodes of depression, is bipolar 2. So what causes this? It is, to a great extent, genetically inherited. Done twin studies, and in twins, in identical twins, the concordance, like both the people having the same illness, the concordance for bipolar disorder is around 60%. And for twins that are fraternal, like they have different genetics, the concordance is 10%. So that tells you that identical genes, if they cause a higher concordance, that means it's genetically influenced. The other causes of this can be, this is more psychodynamic theory, that childhood trauma, childhood abuse, childhood inconsistency in the caretaker, altering between loving and being abusive, those kind of affects the pituitary hypothalamic cycle, their rhythms, and such experiences make it more likely that the person with a diathesis or a likelihood for bipolar disorder will manifest the illness. The cause is mostly genetic. There are some other things that can look like mania, like people that are using speed or amphetamines, any kind of stimulants. They also tend to be, they have elevated mood. They can be talkative, impulsive, rash. And then there are certain medications like corticosteroids, certain autoimmune diseases like systemic lupus erythematosus, degenerative diseases like multiple sclerosis in the brain, where the MS brain is basically is disinhibited, and they may have an elevated mood because of that. Those conditions do exist that can kind of confound the diagnosis. So you always have to rule out medical cause for any symptoms, any psychiatric symptoms. That is the primary role of a psychiatrist. He's a medical doctor who's trained to diagnose medical illnesses first, and then he has additional training in psychiatry so he can correlate those symptom manifestations. And in those situations where the cause is medical or medication related, you always want to treat the primary cause, which is the medical condition, or change their medication or what have you. So what is the treatment for bipolar disorder? The treatment is anticonvulsants and lithium. So lithium is a salt. There was a Dr. Cade, C-A-D-E, the first name of John Cade, is an Australian psychiatrist, and he discovered the lithium, a very important discovery, and then went from there. It's a very interesting story. We'll talk later about that. But anyway, lithium is a good, effective medication. In fact, it's the gold standard. Depakote or divalproic acid is an anticonvulsant used for seizures, but it also happens to help patients with bipolar disorder. There's another anticonvulsant that's also useful. ECT is also a very effective treatment for bipolar mania and depression, by the way, and refractory psychosis. It's a very safe treatment. So you have lithium, Depakote, Tegretol, and ECT, you want to get them enough sleep. Benzodiazepines may have a short-term role in calming the agitated manic patient, helping them to get to sleep. Sleep is very, very therapeutic for them. In fact, you can precipitate a break of mania by keeping a person sleep deprived in one that has bipolar disorder. So sleep is an important part of recovery, ensuring that. So in terms of tips on the treatment, with lithium you have to do a workup. You have to check the thyroid, their EKG, make sure there's no conduction abnormalities, because lithium can affect the conduction of the heart. It can cause QTc, conduction delay, and it can affect the thyroid, so you want to check the thyroid status. Kidney function, although it was more feared early on about the effects on the kidney, but long-term studies have shown that there may be some minor changes, but overall they remain okay. If you keep the lithium in the normal range, it should not be nephrotoxic or toxic to the kidneys. But you do have to monitor for it because some people may be more vulnerable. But generally it's safe. It has to be prescribed carefully. You want to start low, like a 300 milligram once a day, even for a couple of days, and twice a day. If they're manic, you need to rush, then you can go up higher in the initial doses. But be careful, it can cause, diarrhea, tremor, and so you want to go slow on the dose titration. And once they're stable, you check a level. You want to keep the level between 0.6 to 1.2. roughly. Initially they need a higher dose to stabilize, and then you can lower it. You can combine it with Depakote, and you can get away with a lower dose of lithium and thereby less risk for side effects when combined with the Depakote. Depakote, Tegretol, and lithium may be teratogenic. That means they may cause birth defects in children, so in the unborn child. So you have to be very, very careful with the woman that may get pregnant, to warn them and caution them about these medications and pregnancy. and it can be planned for, the pregnancy, and measures can be taken to safeguard the baby and the mother. But it's something that needs to be done carefully under the supervision of a trained psychiatrist. So Depakote is effective as well. It helps. You can load the dose, and it controls the mania. It controls all the symptoms, the flight of ideas, and pressure of speech, and insomnia. They gradually remit. And side effect wise, with lithium, there may be some weight gain. There may be cause hair to fall out, and nausea can be precipitated. It affects the liver, so you have to monitor the liver enzymes and liver function. You should not give it to somebody with impaired liver function or liver disease. Be very careful there. Tegretol is tricky because it can induce its own metabolism, and it can induce the metabolism of other medications that are being used, so it lowers the levels of the other medicines. So it's kind of tricky that way, but it does work as well. Lamotrigine is one that's not really effective for mania as much, but it may have a role in preventing bipolar depression. It can cause a rash, which can be very serious. It's called Stevens-Johnson syndrome. It's it can basically affect the whole skin and slough off the skin. So you have to be very careful with that. Topamax doesn't really have a role, and atypical antipsychotics are used. They're very effective. Olanzapine is good. Clozapine is good. Risperdal can be effective. Haldol has also been effective. But we generally try to avoid antipsychotics or keep them in a lower dose if we can. Olanzapine and Depakote and lithium can cause weight gain, so that's something that you have to watch for. When they do recover, then you want to make sure that they get education, the family's educated. You try to get them to repair their relationships, and if needed, they can even say sorry to the people they may have offended during their manic, impulsive phase. And and the friends and families can become their biggest allies once they understand what the person is suffering from. So anyway, that's a little bit about bipolar disorder. I hope you learned something useful. It's cool, and it's a pleasant evening. Okay, see you later. Okay, bye.